We go with a very simple case of bifurcation that we did in our institution. Essentially, we go straight to the case. We have a 70-year-old male with common cardiological risk factor. He came for a stable angina. He underwent basically a CT scan that showed a severe ostial RCA stenosis with a proximal LAD stenosis, which appeared to be severe. So the patient was brought to our cath lab. You see that on the RCA we have, I would say, moderate stenosis at the ostium of the RCA, which was left behind, and essentially if you see the caudal and the cranial projection, you can appreciate the presence of a long diffuse critical stenosis of the LAD involving also the first diagonal, which appears to be quite big. So according to our internal study, which was the DYNAMITE, aimed to study the complex lesion in which we studied essentially patient at the baseline and at 9 months follow-up, we were able to see with this small study very good outcomes in patients treated with such complex lesion. So these patients was enrolled in this study, and our strategy was to first prepare the LAD, and for do that we utilized a common non-compliant balloon because the lesion appeared to be essentially fibro-fatty and not with a high burden of calcification. You see that the 3 non-compliant balloon was inflated without any trouble, and then we proceeded also pre-dilating the diagonal with a semi-compliant balloon. We also went with a scoring balloon just to optimize the results because of a high amount of fibrosis that we observed. And so we obtained a good lesion preparation of both branches, and then we proceeded with implantation of a bioadaptor 30 by 28 post-dilated with a 3.5 non-compliant balloon at high pressure. And as our practice, we usually do, and we love to do, this mixed bifurcation strategy, so implanting the DES in the main vessel and not caging the diagonal. So we delivered a paclitaxel coated balloon. So the procedure was good. The final results, as you can appreciate by the OCT run, was, I would say, excellent, with a very symmetrical stent expansion. You see the pullback coming on all the LAD. You see also a patency of the side branches, which is very important when you treat the LAD, just to avoid the periprocedural myocardial infarction. So the patient came for the study at 9 months follow-up, and this patient was considered for the sub-analysis that we were able to make. Essentially, we decided to play 2 runs of OCT, one after acetylcholine and one after nitrates, just to observe wherever we were able to find some difference in terms of vasomotion inside of the stent. You see that the angio looks almost perfect, with also good results in terms of late lumen enlargement on the diagonal. You can appreciate here the 2 runs of OCT and also the 2 angio. You see that essentially with the nitrates we were able to observe an overexpansion of the stent, so with a good response to these nitrates administered intracoronary, but at the same time so we have a vasoconstriction of the stent when we administer acetylcholine. So the vasomotor response was analyzed also in some other subjects that were included in our study, and you can appreciate how consistent are the results among this small population. Of course, the numbers are so small to draw definite conclusion, but we were very confident that after the analysis will be definitely positive and able to show a sustained vasomotor reaction in this patient at 9 months follow-up. So I will not go longer, but I will say that essentially this new technology will allow us to treat more complex lesions, as demonstrated by our studies, and of course we will be able also to see a vasomotor reaction of these patients that can potentially benefit from this vasoreactive motion that is not observed with the normal caging with the standard DS platforms. Thank you for the attention.